All right, let's get going. Hello, my name is Will Schmeckley. I'm project coordinator at the Nebraska Medical Association, and I get to work with our great team on this project to bring these trainings to you. Today, Dr. Massey is presenting some patient cases. A couple housekeeping things. This slide here just says that everyone involved in
Hey,
this
Will.
project. Oh,
Sorry,
yeah.
sorry to interrupt you. I'm not seeing
Yeah, go ahead.
this slides. I'm seeing
Oh, you're
just
not
your
seeing the
at the
slides.
top.
Okay,
Yeah,
maybe I shared the wrong screen. Thank you.
yeah, you bet.
Do you see him now?
I'm still
No.
catching your desktop.
Oh, weird. It's okay. Okay. I'll just slide things over. I don't know why it's not sharing on that on that other screen. Okay, wait. There we go. There it is. My bad.
There
Thanks,
we go.
Ed. Thank you. I was sharing the wrong screen. Okay, this slide here just says those involved in this project have no financial relationships to disclose because we're a grant-funded project, um, funded by the State Opioid Response Grant, which is a federal grant that comes to us here at the Nebraska Medical Association by way of Nebraska Department of Health and Human Services. Okay, so I think most folks know here what Project ECHO is. ECHO stands for Extension for Community Health Outcomes, and our ECHO is focused on treating patients with substance use disorders and or chronic pain. We've got a hub team of 6 experts, and I always like to promote our consultation line. If you have some questions, some challenging patients within kind of that realm of pain and substance use disorders, get in touch with me, and then I'll connect you with one of our 6 experts. It could be simple things like, doing a buprenorphine induction for the first time. It could be complex pain patients, psychiatric issues, anything in those categories are things that our experts have helped folks out with. So don't hesitate to reach out to us. And then we do these trainings in cycles of 4. So we're on our second cycle of 4 here. The remaining trainings in this series we've got in a couple of weeks. An individual coming on to share her recovery story, and then Ed's finishing out this series with alcohol treatment in the outpatient setting. Yeah, so we're doing a little bit different process with the CME certificates. Those who were here 2 weeks ago will know about it. Still the same quick evaluation survey. And then after that, within a couple of days, I'll email out a certificate to you. Slightly different. The certificates are a little better than the ones before, so we have to email them this way. But otherwise, I'll stop sharing my screen here and let our Echo expert panel introduce themselves. Let's see. Mary, would you like to go first?
Good morning. My name is Mary Ellis. I'm a psychiatric nurse practitioner and attorney in the state of Nebraska.
Thank you. Ed.
Hey, good morning, everybody. Ed Kaiser, family nurse practitioner in Omaha, Nebraska. Good to be with you guys.
Thanks, Ed. And Todd.
Good morning, Todd Stell. I'm a psychiatrist. Thanks for
Nice to meet
joining,
you.
everybody.
Thanks. I got a note from Stephanie Bennington. She'll be joining us late. Stephanie's a psychiatrist working out in South Dakota and Western Nebraska. So with that, Dr. Massey, I'll turn it over to you.
Good morning, guys. John Massey, and I'm the pain doc uh, here in Lincoln. And I'm going to just try to be presenting some cases today, see if we can integrate a lot of the stuff that we've had. Uh, so with this in mind, I sure hope people want to ask questions. Please interrupt at any time, especially if you have thoughts or disagreements or questions about what I'm talking about. This is meant to be a back and forth as much as I can entice you all into that. Um, when I was thinking about our presentation a couple weeks ago and all the sort of feels like dystopian times we might be living in medicine right now with all the news that's out. Um, it feels like we've kind of allowed back into our society at times some of the darker elements, and I always try to think about how that reflects in medicine and what we need to be doing, to act locally to make sure that we're helping our people out because I think patients absorb that in one way or another. And so I was reflecting on that, and that's kind of some of the cases I'm bringing forward a little bit. And um, we've talked about pain and being a Venn diagram that overlaps with mental health disorders, also overlaps with substance use disorders. Um, and we've talked it several times about how that can look, how we measure that, what to do at different times. And we talk about stigma. We obviously we don't want stigma for any of that cohort of patients. And looking at the news, it feels like we're getting worse rather at stigma. And I was thinking how for a long time we've known that overt racism is terrible, and then even kind of more subtle versions of racism are bad, and I feel like we've slipped in that, right? We've allowed some of the darker elements of that. And so I'm going to say subtle racism isn't cool, obviously, and I think that our people are seeing that we're allowing that lately. The part about that matters in this talk to me is that stigma is a word that we know that we need to uh, not stigmatize our patients, but a milder version of stigma is bias. Okay. And I think as providers, I want us to reflect on biases because when we're talking about this so many times, anyone who's on this echo knows that we're kind of the choir, that I'm preaching to the choir today, but I think our work is never done in this regard. And I'm going to be kind of trying to bring in the idea of bias today and how we need to look at that. And towards that end, what I'm going to be trying to talk about are not just in terms of this differential diagnosis. Are we dealing with a mental health issue? Am I dealing with a substance use issue? Am I dealing with a physical abnormality of pain? But where is the intersection and how do we tell? And one of the things that I think I try to work with, at least in my practice, is when somebody comes into me, I'm not just working in terms of a differential diagnosis. I think sometimes what's an effective way to deal with this cohort of patients is to say, well, there's elements of each of these in each of these patients. Let's kind of get to work on the things that help patients in a holistic way, in just good medicine way, and then let's see what shakes out. So I'm going to try to show you what I mean by that in our cases. And if you guys find this to be annoying, I want you to let me know. But hopefully these are just some cases that make some sense to you. So let's see if I'm getting this right. So you see that first case there, you guys? Can you see that all right?
I don't
First
see it
case,
either.
you don't
I
see
don't
it?
see your slides yet. Yeah, I had the same problem too. It was like sharing a different screen than I thought it was. I don't know what's going on.
Okay. So sorry. Let me see if I can figure that out. Um, it thinks it's sharing though.
Hmm.
Hold on.
You might have to slide it over to your other monitor, Dr. Massey.
Yeah, we were doing that before, and now we fixed it, and now it's on a different one, isn't it? Um, sorry, I'll get to it here. Hmm. All right,
It
so
doesn't show on my end that you're sharing. I can usually see when somee's sharing. It doesn't show that you're sharing. There it comes.
that different?
Um,
Correct
there it
screen or
is.
not? All right,
Yep, I see it. Perfect.
all
And
right.
then you can
Sorry,
just go
guys.
to
All right.
presentation mode on that one.
Yeah.
And
Oh, God, it's never easy, is it? How's that? Is that it yet?
that works. Yeah, perfect.
All right. First case here, you guys, is 43-year-old male. History of low back pain for several years. He's had a 2-level fusion in the distant past. After years of trouble, comes in to us with just the classic trouble for us is just enough medication to come to our first visit. What's really noticeable about this guy is he's visibly prowling around the room, kind of bouncing from wall to wall, sits for a moment, gets up, steps over, leans against the wall, goes to another wall, clearly irritated, agitated, uncomfortable. Um, he's on medications that we're not fully sure if this is the whole story, but quite a bit of gabapentin, oxycodone every 4 to 6 hours. The next question in a chronic situation is, does that mean you're taking them 4 times a day or 6 times a day? Or, what it often means is 8 times a day, but something different than just 40 milligrams a day of oxycodone. His scores are really kind of crummy for us. VAS of 8 out of 10, we all understand. Oswestry index of 56 means he's self-reporting levels of pain that are really functionally limiting him, almost completely limited because of the amount of back pain that he has. He's come to us from another clinic that has left the area, or he can't get back to them for one reason or another. His SOAP score is a score of 12. Kind of would ask you guys to reflect on what that means. If you remember when some of our older studies, when it's a screening study for potential opioid use disorder or problems with opioid use, and it's a scale from essentially 1 to 24. Anything below 8 is low risk. Between 8 and 9, there's concern, and above that number, there's more concern. Up to at levels around 15 or 16, depending on how you look at it, it almost is a diagnostic for OUD. He's not there, but he's obviously kind of been on this medication with less of benefit, not doing well. He's really irritable and agitated, and he's had the usual kind of epidurals and some other injections. He's had therapy. He's not doing very well. And he's also relatively displeased for having to come to another provider. We're not sure we don't believe he was fired by a previous provider. We don't think he was forced to leave, but for one reason or another, he's in our clinic for the first time, relatively skeptical about the ability to do better, not working, wife's there, kind of tearful. You've seen this picture. So the question I'd ask you guys is, with this initial presentation, with our Venn diagram, how are we gonna decide where we want to go with this, what we need to do for this individual to identify what's going on? And if anybody wants to give me a question or answer about that, I'd love to go over it with them. And if not, I'll fill the space. Does anyone want to step in at this point and ask some more directed, pointed questions, or where would you like to be today? I'm pushing us back to the old-fashioned, this is the echo way, but we don't have to do it that way if you don't wish.
Doctor, would you consider doing a psych eval?
Sure. Good question. So yes is the answer. The question is, would we consider doing a psych eval? Yep. I would say that is never a bad answer, right? With our patient profile. The question on this one is, how do we integrate that part of it in on a patient who isn't coming here understanding there's any comorbid issue? But that's a great issue, right? It kind of speaks to our motivational interviewing. How do we sit down and look at this problem from the perspective of the patient? Because he's clearly not there at our initial presentation, despite the fact that he looks agitated to us. So thank you for that question. I love that idea. And
Well,
yes, we would do something like that, but we're going to think about what our timing is on that. That's about effectiveness. Yeah.
I guess I would present to him that you are working as a team. You want to meet him where he's at.
Mm-hmm.
And part of looking at the whole person would be to look at alternative ways of figuring out how to help him with his pain.
Great. I love that. And then he says to you, he says, Joyce, you think I'm making this up and this is in my head?
No.
I hurt. Don't you understand that I hurt? Now your reply would be,
I believe that you feel pain, that there's problems here that are causing you to have a poor quality of life, And what I want to do is work with you in every way possible to help you feel better and be more functional and have a better quality of life.
Absolutely. That makes a lot of sense. Does anyone, clinically, that's completely correct. I would agree with that. Anyone have any other thoughts about that approach?
Um, I well, I strongly agree because I'm primary care screening a lot of people for depression.
Yeah.
I I think it's most people could understand that you're in pain all the time. This it is not unusual to be depressed or et cetera, or
Mhm.
anxious because you're in pain all the time. I think it's
Mhm.
even the layperson will understand that.
Good. Excellent points. Um, I would always, I would say as a pain provider, that's exactly where we feel somebody ought to be. And we have to be way more careful with that. That you couldn't put on one hand the number of Google reviews that say these guys didn't try to figure out what's going on and they think it's in my head. We have to be very, very careful about that. And the point I would make, the counter argument to that is all of those are correct. We should certainly be doing some screening studies for depression. Absolutely. We've already got a screening study for substance use that shows we're in the yellow range, if not the red range, right? How do I fix that problem? And what's the order of things to address? Does that point make sense to you all?
Yep.
Okay. So and I think you're right on it in terms of where we want to go, except um, I took a little different approach, and I'll explain the why behind that with some other data. Um, so what the approach that we took is, all right. So how long have you been on the oxycodone? I've been on it for probably 10 years, right? He had fusion surgery finally after several years of failure. He's been on this medication. He's not working. He can't do anything. How you doing? Your pain is out of control. You don't feel well. How about if I present you with a medication first that makes your pain better? Are you interested in that, Mr. X? Okay, now he's listening. He's very skeptical, very frustrated with the idea that he has to see a new doctor and he's already going to switch the medicine around, but he's listening, right? He had enough medication to get to me, but he didn't have any more. So the first thing I said is, I'm going to write a renewal of your oxycodone. I'd like you to really tell me how you're taking it. So I want to know if it's 4 times a day, 6 times a day, or if it's 10 times a day. I need to know that because I can't change it unwittingly because it's written one way or doing it differently. I did that, but then I also said, I can make you are never going to be more comfortable on higher doses of oxycodone. We have learned over painful 20 years that the second you start that uptick in your legacy opioids with any individual for chronic pain, you've lost the game. If it worked for a while and you go up with the dose, you will never find another legacy opioid, no matter how high you go with that, that will recapture therapeutic benefit in a sustainable fashion, meaning for more than 2 or 3 months. So if you go from 3 a day of hydrocodone to 4 a day of oxycodone to MS Contin to fentanyl, you are just on that roller coaster all the way up. And the neat part about, like we talk about buprenorphine, is if I can translate somebody to buprenorphine, that is a different situation. In other words, when I get them to buprenorphine, that there's level 1 data that shows that it's better for chronic pain while it's safer and more importantly, it's sustainably effective. So if I get them to 1 milligram, 2 milligrams, 3 milligrams, or 16 milligrams of buprenorphine daily, they're going to have a reduction in their pain from whatever their opioid dose was, and they're going to sustain at that. So we took that approach. And the reason we took that approach was one, a little bit of safety, but more importantly, we could not have to have that discussion with the patient that redirected their thinking more than they were able to handle. And what we did is we said, all right, we're going to switch you to buprenorphine. We did the microdose induction that we've talked about. I'm going to give you a couple weeks of your oxycodone, and I'm going to sneak in this buprenorphine until you don't want your oxycodone anymore. And you pick when you stop it, but I'd like you to stop it at about the time you get to 3 or 4 milligrams a day of buprenorphine, which is exactly what we did. And he came back 2 weeks later, and his dose of oxycodone had been reduced to one oxycodone a day. He took it at night because that's when he kind of got edgy, and he was at 3 or 4 milligrams a day of buprenorphine. But his comment to us was, I still feel edgy all the time, irritable. I'm not sure it's working. My pain's no better, but it's also no worse. And so we figured out that we could go up with buprenorphine at that point, at the 4 milligrams. And ultimately, interestingly, we ended up at 12 milligrams of buprenorphine, which is a higher dose than we would have expected. And that higher dose, does anyone want to think about what that reflects for us in terms of what the implications are of 12 milligrams of buprenorphine for a patient versus 4 milligrams or 3 milligrams? Not trying to be a guess all, but here's what happens is what we're finding from that is when people are using buprenorphine for predominantly, symptomatic relief of pain, they tend to be around 2 or 3 milligrams a day, very stable. Once they get beyond 4, which is Ed would tell us, 4 milligrams a day is like the limit of safety for somebody with use disorder. They need 4 milligrams kind of continually in their body in a day, or they lose their safety with use disorder. So it's almost like the higher dose that an individual wants to take before they feel better, the more likely that we were into dependence physiology rather than just analgesic physiology. So to me, what that indicated is, well, you know what, we might have kind of nipped a budding use disorder developing as a result of extended use with legacy opioids. And the nice part about that is we didn't have to confront the patient about that. The edginess, the mood stuff was settled down quite a bit. They weren't so desperate for relief, but they were still having some pain. And he was still describing pain 5 out of 10, 4, 5, 6 out of 10, that kind of thing. But he saw some progress. So now he was listening to what we would do next. And I think getting that formal psych eval would have been a very appropriate step. But the step that we took instead was interesting for you all, and it's kind of what I want to show you here. We wanted to say, all right, let's see what's really going on because everything's failed for you, and we know you haven't been doing well for 6 years. You've had a bunch of injections. Can I try to figure out what's going on with your pain? So he was very happy for that. So we got a new MRI examination. This isn't his, but this is kind of reflective of what he had. So this is an individual on the right who has a fusion. You see CT imaging, which shows good fusion hardware, et cetera, et cetera. And that's what the old images would have told us. They're happy with this. There's a little bit of change. Does my pointer show up in your picture? A little bit of change at that junctional level seen on CT imaging. But the comment from the radiologist was no new stenosis, good hardware formation, no subsidence, and good fusion. But when we get the MRI over on the left side here, lo and behold, what we're seeing at the junctional level is this right here. And I don't expect people to come at, tell me what's going on here, but these are modic changes. This is a classic sign of vertebral body pain, discogenic pain, axial back pain. And by the way, it's exactly what makes this person prowl around in the room because the last thing anybody with this wants to do is sit in a car or sit down for an hour at church or in a meeting at work. They just can't. It hurts too much. After these people are wandering around all the time because it hurts in their back and all of this. And this was going on at the junctional level above his back, right here. So what we had was an anatomic marker for the kind of pain that he was reporting and the limitations that he was getting would be expected with this amount of problem. And he'd been getting care for a long time. He followed up with his primary surgeon who said, I'm not going to do another fusion on you. You're 42 years old. You're not doing well with the first one. And you've got junctional change. They're reasonably saying we don't want to fuse you. He had a bunch of epidurals and what have you done for this. And that's not something that's going to help him. But the neat part about this was I could say, look, you got something wrong here. And oh, by the way, we could fix it. And so at this point, we had reduced his pain by about half. He had this anatomic change here. We offered him the definitive treatment in our mind for that, which is a basivertebral nerve ablation, the Intracept procedure, which we performed at this level and this level. And 4 weeks later, he came back to us and he was still on his buprenorphine. He was now on 6 milligrams a day. We put him on that perioperatively to help him keep comfortable procedurally. And he said his pain was down at 2 out of 10. All right. So next question is, you don't have your pain. You're better anyway. He sees progress and the wife's in the room. His pain's reduced. We've got medication that's stable. We found a procedure to make him better. Guess what we did at that point? We got our psych eval, right? And we did get an eval. We had obviously there was anxiety, there was sleep disturbance, there was interpersonal difficulties with the wife and long-term dependence. And there was also a tendency to displace psychological stress into physical symptoms. And I bring that up because somebody along the line had recommended a spinal cord stimulator, which is something we do. And with those findings, we probably would have been reluctant to do that. But the real reason is all of those things are behavioral comorbidities, along with the idea that he was misusing medications just a little bit. But fundamentally, we found something that we could do that would make a significant alteration in his pain and functional capability. It didn't obviate the need to have everything else. It gave us the opportunity to have the patient accept that. Okay. So in the context of this discussion, what I'd like to say is, yep, we have all of our challenges with these Venn diagrams, but the whole key here is what's the right order to knock things down and how can we be discerning about that? Because I'm pretty sure that if I would have told him right away that I want to switch you to buprenorphine and we got to cut you out of your oxycodone because your SOAP is 12, he'd have fired me on the spot and he would have gone back somewhere else. I'm also pretty sure that he's that uncomfortable and I send him away with the idea that I want a psych eval, he would have said, I would have got the big old FU from that as well. And he would have left where maybe he would have gone on. And what he probably would have ended up with is a fusion and a really bad outcome because fusion surgeries are not good for making modic changes better. But instead, we were able to say, look, let's make progress, chip away at the things that we can, see if there's something we can figure out and go from there. So it's a very interesting outcome. By the way, he's still on his buprenorphine. He still has pain that sometimes when he gets really stressed, it goes up to 6 out of 10. But most of the time he's hovering around 2 and 3. And he fully accepts that. And he is currently in an ongoing fashion attending counseling, sometimes individually and sometimes with his wife. And he is returning back to work. So all of those things I think are a good outcome. They're subtotal, of course, but now we've got a sustainable way to manage that. And we've been able to have that conversation that brings in all elements that we all see when we're seeing those patients. Does that make sense to people?
Yeah, that's great, John. I have a couple questions.
Of course.
I love what you mentioned earlier about this, like you're on a legacy opiate and you need to step it up and you're never going to get the pain control. I see so many patients that are like, in my world, they say, hey, I have a high tolerance, right? And tolerance develops, right, over time. And so can you explain that a little bit more? And how do you have that conversation about like, hey, which you've said before, like increasing opiates isn't going to fix their pain, but that was like different how I've heard it from you before. So
there's a couple of key thoughts to have in your head when you're talking with a patient. And the first one is, I think it's pretty important to meet a patient and say, I get you have physical symptoms of pain. And if we're only worried about that and nothing else, I need to do this, which is I need to switch you to this medication. Why? When we talk about tolerance to opioids, and the real crazy one was, remember when we used to do all this opioid rotation? Oh, you're sick of your oxy? I'm going to give you some fentanyl for a while, and then we're going to go back to oxy. It never worked, ever. Patients just, it sort of made them feel better for a while, and then they dropped back where they had to switch. And the rotation thing was just empty. And the same thing that didn't work was switching those people into intrathecal pumps. That's the other thing that we found out why they failed. But it's not because the medication is being metabolized. It's because the exposure to that opioid receptor, any medicine is going to work partially, right? If you break your leg and go to the ER, morphine is going to work for you. But if you have chronic pain, the best I could ever do, even in the short term with an opioid, is manage it for 3 to 6 months and reduce it by about 30%. Kind of like what Lyrica would do for nerve pain. So naturally, as we try to go up and up, we're losing the mu activity, the opioid part, and now we're just ramping up that dopamine part, which eventually turns them into somebody who's got that issue going on. So two things. One, it's once upward titration never works. You'll just get to the same level of pain at a higher dose that's higher to manage. So the sooner you fix this problem, the more likely it is to be easy for the patient. And then when it gets really bad, the other terminology that we always like to kind of help people understand is it's never possible to successfully treat chronic pain in the face of untreated use disorder. Full stop. You want your pain better? I've got to address the use disorder. And the most dispassionate way to explain that to the patient is the most effective. No blame, no, you're being naughty, none of that stuff. It's like, this medicine's not working. I need to help you. And the great thing is we've got an easy way to do that. We just have to get used to how you dose this medicine and being adults about it. And take out bias and stigma entirely because they're looking for that. They're shaming themselves internally, whether you believe it or not, or you see it or not. And we have no role adding to that. And the worst thing I see all the time is somebody who gets in this spot from a prescriber, and it's oftentimes a pain prescriber, and then they fire the patient because of a problem that the provider created. That's absolutely abhorrent to me. Do not do that. Do not do the easy part and leave the hard part for the patient to worry about hopefully finding something else in the future. And if I can get on a bigger soapbox than that, I would, because that's just, I think, irresponsible. And we all see that when people don't think about this. So thank you for bringing that up, Ed. Want to go to another one?
Sure. We had just a couple of comments I'll read
sorry.
quick. One question in the chat, so I'll just read the comments quick and we can get to that quick question. Joyce followed up, just said, absolutely great management. I think the order you used is great and your outcomes prove it. Early in the conversation about the psych eval, Amy said, I've had a lot of new patients walk out the door if you start there. And then here's the question from Stacy. How do you stop the pain doctor versus psychiatrist? Pain doctor has me on bupe. Now I want more benzos from the psychiatrist. How do you incorporate collaboration?
Wow. Well, okay. So you guys want to go another hour, right? Because that's a big question. Um, so collaboration's on us and mutually respecting what's going on. My thinking in that regard is I can so the worrisome part about co-prescribing opioids and benzos is that they add up, right? They're synergistically bad for respiration and other issues. And I can make that dramatically better by going to buprenorphine, right? Somebody's not going to very likely overdose in a fatal way if they're on benzos and buprenorphine. Even really, other things like stimulants and what have you. But so if I can handle the part of it that I can handle and reduce that kind of irritation, agitation with the patient, I'm now setting up the best way for them to get away from the benzos. And then it's just a discussion between the different providers, kind of who wants to take the lead in that and who wants to be the second one to help with that. So if it's a matter of saying, my job in that case, so if Dr. Stoll and I were working on that patient together, what I would probably suggest is I'm going to talk to the patient about the lack of benefit with most benzos on muscle relaxants, right? Somebody's talked them into this is we don't use muscle relaxants and we certainly don't want to use benzos for that. I might say, could we switch to clonazepam as the initial thing? And then on a side discussion with Todd, say, I know you've told me it takes a really long time to wean somebody away from benzos. Are you ready to start that now? How can I help? Or do you want me to do it now? And can you give me some, that kind of thing? It's that one's a real team effort because it's not going to be something we can accomplish in 3 months most of the time. But if we reduce the risk of what's going on, harm reduction says now we've bought the patient time. And by the way, he's feeling better with his pain. So he's going to be like, that one counterintuitive thing worked. Let's see if another one does. Because these people will feel better on SSRIs in the long run versus benzos if it's about anxiety. So great question and hard answer, I suppose. I don't know if that, does anyone disagree or would they take a different approach? Okay. Should I go on?
Sure.
I gave you the easy one. I gave the one I was happy about first. And so, all right. Case number 2. This is a 39-year-old patient, similar in age. This guy has had a decompression many years ago, lumbar decompression versus a fusion. He has persistent axial low back pain. This guy's on similar doses, but it's hydrocodone, it's cyclobenzaprine, and duloxetine. Recently getting worse, so they put him on a little bit of Ambien for a while, but it didn't really work. And so sitting on that, comes into us, same scores, terrible pain, enough med to get to us. We do this was an osmometry score of 64, SOAP score of 3. I didn't write the ORT down, but it was also kind of super low. Of course, we do our first urine drug screen, and there's cannabis in this, alcohol, and amphetamines. And I'm just going to tell you, just to expedite, at subsequent monthly follow-ups, those medications persisted. So I've got that. This patient it's kind of to me remarkably similar. And how I remember these guys is I don't have a lot of thin young guys with lots of tattoos, but otherwise they look like, they could just be hanging out at a sports bar with a bunch of buddies and they would fit in. But these two guys looked very similar on first presentation. And this guy did come in after that other guy, and I'd had some success. So I was feeling a little sassy, as you would guess. Okay. Who wants to say where should we go from here? Yeah. All right. Let's just expedite this and say I was feeling pretty, let's see if I get there. So we took the approach with this gentleman that was similar. We talked about the medicine. He was really irritable about changing the medication at first. So he didn't want to do it. He was new to us. He had not a lot of success. So what we actually decided to do was to continue his medication without dose adjustment. I plugged my nose and I wrote for 4 times a day, hydrocodone 10 for a month, and I ordered an MRI examination. And I said, let's go over that MRI on follow-up in a month. And we did that. He'd had he'd had this persistent back pain, and the part of this I want to make sure I clarify is he's had lumbar surgery in the past, but he had a decompression. And for those of you who aren't medical, decompression is not even attempting to make back pain better, right? Decompressions are indicated for radiculopathy or sciatica. So sometime in the past, he had radiculopathy, and a surgeon opened up that foramen for the nerve, which must have gotten better because he isn't talking about sciatic pain right now. He's just talking about back pain. So I thought we were going to sort of see the same thing, right? He might have everything going on. And what I'll tell you is we got an MRI, and again, this isn't his, but the MRI and the picture on the right is kind of normal looking MRI findings, and that's what we saw with this guy. There was not anything other than the defect from the laminectomy that was performed in the past. There was no indication of any disease process. That doesn't mean that there's not something there. There's a little bit of evidence that he's had chronic pain. If you look here around the facet joints back here, those are the multifidus muscles. And all this white here is an indication of chronic multifidus muscle dysfunction. And what that means is the pain's bad enough that those nerves, those muscles aren't working, they're not firing, and they're becoming atrophied and fibrous, so that they're not. So that's kind of a sign of chronicity. It's a little bit like when you go to the chiropractor and they say loss of cervical lordosis, and that's a sign of what's wrong when it's really a sign of the fact that you have pain, so you're holding your neck differently. This is a sign of chronic change or chronic pain, despite evidence, a lack of evidence to find what's going on. Interesting to us, right? So we couldn't quite figure what was going on with this gentleman, but he also had the same presentation where he was wandering around the room, cranky, irritable, things aren't right. He was just agitated all the time. And so we tried to switch him into his buprenorphine to see if that would help. We can get better analgesic efficacy with that. And he came back a few times with problems with that. He didn't like it. It made him too drowsy. He was worried about his teeth, and his urine drug screen, each time he came back complaining about side effects, his urine drug screen didn't have it in it. So we weren't progressing with this guy at all. Now, somebody give me some thoughts. Anyone? Joyce, you want to step in? You were so helpful before.
Yeah, this is
Oh,
Lindsay Myers, I'm family practice,
hi,
and
Lucy.
how do you address the abnormal urine drug screen initially going when you meet this guy so that he knows kind of what your expectations are?
Yep. Well, great question. So our expectations in this regard are not to have illicit substances in your urine drug screen, right? And so what we do is we do that first. We don't have those results first, and they go away and they come back 2 weeks later, and or whatever time period later, and we're like, hey, by the way, quite a bit of stuff going on here that we wouldn't expect. Anything you want to tell us about that? How do you want to talk about it? And, they immediately get that kind of, well, I had we've all heard a million stories. What we basically say is illicit substances are not compatible with me prescribing a combination of cyclobenzaprine, Ambien, and hydrocodone. I like to use it as an accelerant into what we would want to be doing anyway. So you can make a decision as a grown-up about what substances you're going to induce, and I'm going to make a decision as a provider about how to keep you comfortable, and even more importantly in that instance, how to keep you safe. So it, to us, is a reason to switch to buprenorphine of itself. Because if this person came in saying, hey, look, I got a problem with stimulant abuse and I'm taking hydrocodone, I'd say, all right, let's get you out of hydrocodone because one of these days you're going to take a cocaine laced with fentanyl. Let's try to stop this as fast as we can. So then we'd accelerate into the buprenorphine treatment, and we'd be more upfront with the idea that this is a use disorder, right? And obviously there's some misuse of substances for sure, and we were concerned. So that's how we would address it. And the thing that's interesting is the alcohol backed away and the THC was present on one and not another, kind of back and forth, but the amphetamines always stayed there. To me, that was very interesting and problematic because now I've got a patient with persistent symptoms of pain. He didn't like the buprenorphine switch. He wasn't doing well, and the urine screen was coming up abnormally each time. This is when, Joyce, I'm going to take your son. This is when we did insist on sooner rather than later, I needed a little bit of a eval. And what I sent off is, can somebody please tell me if there's an issue with ADHD in this individual?
It could be ADHD, or he could be using it because with hydrocodone, cyclobenzaprine, and Ambien, he might be more tired than usual. I'm not saying he doesn't have ADHD.
Yeah.
The other thing I would ask is why there's no buprenorphine showing up in his urine drug screen.
So it kind of went like this. The first one, this was the results from the first one. The second one had both buprenorphine and hydrocodone in it. And then the third one, he came in, and that was actually, we were seeing him sooner because he looked terrible, right? So the third one was at 4 or 5 weeks after initiation of our care, and it just had the hydrocodone in it, or maybe it even didn't. It just had amphetamines, but it didn't have buprenorphine in it. And he was telling us he couldn't take it. And we kind of treated that as, you're not really doing what we want you to do. You're not buying in, and we're not getting better. What's really going on here? And so, we weren't going to change what we were going to do. If the buprenorphine showed up one time and not another, okay, but the hydrocodone couldn't stay in there. But fundamentally, great points. That was when we were like, we need to go on further, because it could just be substance use. And maybe this is just a person with stimulant use disorder, or maybe this is somebody with an ADHD, and we need to get something better than, I didn't know whether he was on, methylphenidate that he was taking from somebody that wasn't prescribed, or whether it was methamphetamine. I might have been able to tell, but I knew we needed more information. And so that's where, to me, I'm not dealing with an anatomic pain problem, but it's beyond me to say whether I'm dealing with a mental health condition and he was modulating that, or whether it was only substance use or a combination. That was my suspicion, but I needed immediate help because what I was communicating was making no progress with this individual over the course of a month. And to me, it would have been irresponsible to go on any walkabout with any of the procedural things to try to find a source of pain with a relatively normal looking MRI, without having that handled first.
What would you say to using trazodone instead of the Ambien at night?
Sure. Yeah. Oh yeah, we would do that typically. Yes, for sure. For sure. Yeah. Or even nortriptyline, but something really, I still need to know, is it a good idea or a bad idea for him to have amphetamines in his body at any dose? Because if you evaluated this patient and said, you know what, there's a lot of impulsive behavior and all this stuff. I see this is ADHD, and we recommend that he be seen by a provider who starts prescribing methylphenidate or something. That will probably, and Stephanie, I don't know if she's on here yet. I've learned from her, you're not going to make substance use better unless you treat the ADHD with amphetamines, and then you got to do everything else right to keep these people safe and comfortable.
But there are some non-stimulant, quote unquote, ADHD medications, including some really good ones.
Understood. And I'd bring it out to smarter minds than me on that, is like, okay, given this presentation, where would we fall in terms of, would we if we did in fact deal with have a diagnosis of ADHD, would we, knowing what else we know about this patient, would we try to put him on a non-stimulant for ADHD and hope that his stimulant misuse goes away? Or would we say, let's put you on the right amount of stimulant that's prescribed for medical reasons and see if your stimulant misuse goes away? I do not know the answer to that. I'm asking smarter people on this panel.
I would sure start with the non-stimulant, but, and also the amphetamines could really confound. This is just my opinion. I don't think they're a good mix with back pain unless there is a medical reason for them. Now, with ADHD, absolutely a great reason, but you're going to have to tease that out. And I think one thing you could do in the office is there are adult ADHD screens you could give him, and you could blank out what you're looking for. In other words, don't have it say ADHD screen, just have the questions and have him fill them out while he's waiting to come in and see you.
Yeah. Okay.
And coordinate. Absolutely. I'm so glad you talked about people talking with the psychiatrist. talking with the family doctor, because that's what I see as a big problem. Nobody calls you back, and you have to be persistent. End of soapbox.
Which screens do you use that you feel aren't like pointing the patient in the direction of ADHD?
Well, let me pull out my little booklet here.
So let me chime in here a little bit. This is the world where I've lived in a long period of time. There aren't any. Okay.
Yeah.
That is the bottom line, Dr. Hay. There aren't any. Now, and you can do things like continuous performance testing. You can use a CARS and get additional information from a teacher, from a parent, and so on. But the self-rating scale is going to point you to that direction. So here's the way I approach it. I have to prove in my own mind that it's ADHD, and I don't think that way initially. I have to know for sure that even if it's untreated, those symptoms start prior to the age of 12, and you have collateral history to support that. Because from what we know in all the studies, ADHD doesn't all of a sudden kind of surface when you're 24 years old and using Flexeril and hydrocodone and so on. You have to have the symptoms before the age of 12 with functional impairment. What happens for untreated individuals is as they go on in their life and their demands increase, whether it's from college or work environment, the compensatory or workaround strategies for untreated ADHD, where their symptoms start before the age of 12, don't work anymore. In other words, their compensatory strategies and their ability to adapt doesn't work as well anymore. So then what do you do? How do you say, well, gee, is this ADHD? I have to prove in my mind, number one, it's not due to something else. Anxiety can look like ADHD. Sleep deprivation can look like ADHD. Medications, side effects can cause symptoms that look like ADHD. Oh, I just can't focus. I'm distracted. Well, that happens with a lot of different medicines. That happens with people that are sleep deprived. It's a cardinal feature for someone who's anxious and not being able to focus or getting distracted. So I have to go through kind of in my mind, this is to make sure it's not something else. I don't go to a rating scale right away. I go to, do you have these things before the age of 12, these symptoms? Do you have collateral history? We've talked about family and so on that support this diagnosis. And then I look at, are there other possibilities that you look at that could explain the symptoms? And remember, one of the great kind of misleading things that's across many psychiatric diagnoses is the concept of impulsivity. It's not unique to ADHD. People that have bipolar disorder have impulse control disorder. Many of the personality disorders have impulse control problems. And so I really look kind of a little bit broader, and I would discourage going right to a scale up front without thinking through the process, because it may not, you may be kind of treating the symptoms on the surface, but not the real core issue of what's going on. So I'll stop there, but that's kind of how I would, give you some things to think about, to consider before you jump into, hey, this is ADHD. It could be, right?
Thanks, Todd.
That's thank you, Todd. That's exactly illustrative, because I know I'm not going to be able to figure out from my chair what's going on there. And I'm also, therefore, I know I don't want him on these substances, and I know that needs to change, but I don't know how to counsel it with respect to what to do with that, right? I know I don't want you to have THC and hydrocodone. Do I feel a lot better if I've got buprenorphine and your pain is a little bit better, but you're still kind of out there with these urine screens? Maybe. But now, what do we do with that? Am I going to make any symptoms better if I'm doing what I can do versus collaborating with what Todd can do, or Joyce, or the others? So I think this is something that we see all the time. And again, you've got to put a wrap around all of it in order to make any progress. Great question. He's currently sitting at this spot. I haven't made progress with him. He has moved into buprenorphine and only reluctantly. Um, and he's either gonna get a little bit more serious about the behavioral aspect of this, or he may leave our clinic. And I haven't determined if I'm gonna just lose him altogether yet. Where are we? Do you want another case, or are we at end? Will?
It's up to you. We've got 4 minutes if you want to do a quick one. Whatever you
Quick. Yeah, I'll just give you another one. This one's interesting to me. And believe it or not, these are de-identified three real patients that we've seen in the last month. But this is a 42-year-old, so same age. His problem is chronic knee pain, also on oxy 4 times a day, methylphenidate. Now somebody's prescribing that for him. His MRI images of his knee, back, everything's normal. Nerve conduction studies are normal. He comes to us on oxycodone 10, and he comes to one of our outlying clinics. What's interesting about him is he has been forced to leave other practices multiple times because of a reason that we can't find out. And as we develop in our care with this individual, limitations on what hospitals will see him, mostly because, from what we can gather about that, mostly because he calls repeatedly and complains, and he's mad that nobody's taking him seriously, et cetera, et cetera. So this individual, very similar kind of a presentation. There's an overriding issue of something other than his chronic pain. What the genicular nerve block being negative means is we've numbed up the knee we've blocked the nerves to the knee, and it didn't help. We don't tell an individual what to expect with that, but he says, while it was numb, I didn't feel better. But everyone says this is knee pain, and he's been thinking about whether he's going to have knee surgery. Nobody will do it because it's a fully normal knee. But we've kind of got objective evidence that it's not an anatomic structure, and he's on these medications. 4 minutes time. So what's interesting about this individual, that what I would have gone through if I would have gone through these more closely or more quickly, we switched him to buprenorphine after a discussion about, let's make your pain a little bit better, see what's going on. Buprenorphine might be more effective for a neurogenic or nociplastic pain, something that's not anatomic. We don't really talk about that with the patient, but we understand that. And what happened then that was fascinating to me is he listened and shook his head, and we spent a good 45 minutes in this discussion. I was kind of the second person in to have that discussion because it hadn't gone well the first time. And the next thing he does is he calls it wasn't even the hospital where he had seen me. He calls another hospital and talks to their risk management person or whatever that is to complain about the care he's getting. They didn't listen. They don't do this. They're not doing this. I need this. I need this. I need this. I'm not going to do that. And the part about it that I thought was interesting, not only did I get an 8-page, HR thing saying, hey, this patient feels unheard and all that stuff by any of your visits, mine and a couple others from previous providers with us. The part that I thought was fascinating about it is for the fact that he called and complained about really everyone that he had interacted at a different hospital, they gave him a $20 gift certificate to Starbucks. And so to me, it felt like it was kind of anti-contingency management. Like, if you don't want to listen to what we're recommending and you call us, then we'll just pay you off for not doing what we're trying to get you to do. And I thought that was a very frustrating turn of events, but now we're stuck a little bit, right? Because we obviously don't have good alignment with the patient. And moreover, he's got a history of poor alignment with people. People are just quitting on him left and right. It's pretty hard to get a hospital to say you can't come to the hospital, but that's where he is. And now where are we? We're stuck with that. So, that's our cliffhanger because I don't know what to do at this point. So you got through that case in less than 4 minutes.
Hey, that was great. Well, maybe if you get a chance to do some updates on those, maybe next time.
Yeah, I'm
Um,
pretty sure it'll be bad news, but
yeah, yeah, true. Well, hey, that was great. Appreciate all the conversations and participation from our participants. That was awesome. Looks like we're at the end of the hour, so I guess we'll call it here, but maybe we can get back to some of these cases in our next session, Dr. Massey. There is a link in the chat to grab the evaluation survey. and I'll also be emailing that out later. And then we'll be back in a couple of weeks. We have a patient named Haley coming on to share her recovery story. So hope to see everyone back then. Thank you.